presentation is brought to you by Dartfish, and we are the global leader in digital video analysis. We're utilized by sports entities and many healthcare facilities around the world, and we are the choice of champions. Over 400 medalists from the last Olympic Games utilize Dartfish in their everyday training. So let me introduce your moderators today. Frank Merrick is with Dartfish. He's a regional director and a specialist in physical therapy in the medical field, and he joins us from Chicago. Welcome, Frank.
Hello, everyone. Hello, everyone. Hope you're having a good day.
And I am Deborah Stewart. I'm the training director for Dartfish, and I'm here in Colorado Springs. And we will be your moderators today, answering your questions and assisting our presenters. Our presenters are Trent Nessler and Ella Dunn. And Trent is the CEO and founder of Accelerated Conditioning and Learning. He holds a bachelor's degree in exercise physiology and a master's and doctorate in physical therapy with a focus on biomechanics and motor learning. Along with treating high school and collegiate and professional athletes for over a decade, Trent has also worked with employers to develop exercise programs to reduce work-related injuries in the tactical athlete. He has used his passion for exercise and his clinical expertise to develop and research DMA, a dynamic movement assessment, as a way to improve athletic performance while reducing the risk for injuries. He's the author of a book on the subject that will be available soon, and he offers certification courses throughout the U.S. Trent is joined by his business partner, Ella Dunn, and she is a partner in Accelerated Conditioning, as well as the owner of Performance Enhancement Services, which is an organizational development consulting practice in Nashville, Tennessee. Ella has worked with clients in the healthcare field to enhance performance on the bottom line through focused improvement and planning operations and processes and marketing. So her work area of expertise is vision building and mission clarification with core competency development in enabling individuals and teams to reach new and higher goals. So let me, after that introduction, let me switch the screen to Trent and look forward to all of the information he's going to share with us today.
Thank you, Deborah. Thank you very much for everybody for joining us. And thank you, Dartfish, for allowing us the opportunity to truly share what has been a passion of mine for the last 15 years. Today we're going to talk about the dynamic movement assessment, really about movement assessment in general as a way to prevent injuries and drive athletic performance. For me, this started approximately 15 years ago as I was seeing a rash of ACL injuries come into my office. For me, this resulted in a professional pursuit of continuing education and research into the area of movement. Over the course of that time, we have developed a dynamic movement assessment, which is a movement system that utilizes video technology to accurately capture and quantify human movement. We've also just finished a e-textbook, college textbooks on the subject matter that will be out in the next 30 to 60 days. And it's a 396-page college textbook covering the full scope of some of what we're going to touch on today. We are also continuing our research and development of the dynamic movement assessment. Obviously, as research continues to change and as research continues to occur, we want to make sure that we are updating our movement assessment and the methodologies that we use to reflect the most current research that is available. People don't know what they don't know. This is a quote by Victor Bergensolian, and really rang true to me and really emphasized the importance of video capture of human movement. You know, I think any of us can look at the picture of this young athlete performing this movement and realize where her movement deficits are. But human movement is so complex and occurs at such a rapid rate that many times capturing that in a clinical setting and really from an intervention standpoint is very difficult to do. One of the things that I've really enjoyed about working with this video technology that's really allowed me clinically to evaluate human movement to a much higher degree. So why ACLs and why the focus on ACLs? Really, a lot of that comes from the research. You know, ACL injuries, as we all know, are the injuries that we tend to hear about the most. They're some of the ones that are the most costly. They result in our athletes being on the disabled list a lot longer and have a lot of downstream cause and effect as a result of an initial injury. Even current research is even as of March of 2013, we're finding that the numbers are much greater than what we ever anticipated. For example, in a recent article published in the American Journal of Sports Medicine, we see that 79% of athletes who have suffered an ACL reconstruction have osteoarthritis in 12 years. We're also seeing that 20% of those who have an ACL reconstruction have a second ACL reconstruction within 2 years. And of those that have their second ACL reconstruction, 40% have other pathology that also goes along with that. So whether it's a bone bruise or a meniscal tear, etc., they also have other injuries that tend to go along with that. We're also starting to see that return to sport percentages are much lower than what we initially thought they were. Again, in the American Journal of Sports Medicine article published in 2012, we're seeing that published return to sport for ACL reconstruction for high school football players is 63%. 69% of college football players who have an ACL reconstruction return to sport. I think the thing that was the most surprising to me was that even though those percentages are lower than what we initially thought, was the fact that 43% report returning to the same level of play as they did prior to their injury. So not only are less players returning to sport, but those that are actually returning to the same level of sport is much less than what we originally thought it was. So looking at the annual healthcare cost, it is astronomical. You know, over the last 15 years, we have developed a lot of research. There's been a lot of research around preventing ACL injuries. And what we're finding is that over that time, we've only had about a 1.5% reduction in the rates of injuries for ACLs in just the last 5 years. Last year, there was over 250,000 ACL injuries and an annual healthcare cost of over $5 billion. So the reason that we focus on the ACL and the pathokinematics associated with the ACL, one, it's the most expensive. Players are on the DL for the longest period of time. The impact to future health care as well as their performance is great. And we know that a lot of these pathokinematics are also associated with other lower extremity or lower kinetic chain issues. So very briefly, what we'd like to do is just show you a case example of a U.S. Olympic athlete, 23-year-old steeplechase athlete. And what we have here is a video of her performing 4 of the 6 essential movements that we go through in the dynamic movement assessment. If watching this video, I think any of us that see this video can see that she has some deviations when she does a squat. This particular deviation we term as a lateral shift. If I go down here to my key positions and look where I set my reference line, we've set a reference line here, we've measured it and moved that over. We set a plumb line along mid-spine, and we do that right before the athlete actually starts to squat. Because so many athletes tend to move around so much right before they squat, we wait until they actually initiate the squat. And then here we actually measure the lateral shift. In this particular case, she has a lateral shift of greater than 3 inches to her right side. If we look at her step up, I think any of us, again, that view this video, we can see some deviations that she's presenting with. With Dartfish, as we go to our key positions, we set our reference point, which is at the medial aspect of the foot. We document any deviations, and we call this a retro Trendelenburg, where she's bending, side bending to the opposite side. And then we're measuring the magnitude of the deviation where she is adducting past midline. If you see right here, you can actually see her knee is breaking the midline point. With the use of some of our Dartfish tools, we can blow that up and actually see that she's slightly breaking that midline with the step-up motion. Looking at the single leg squat motion, again, we film the motion. And as we can see, some significant deviations. We use 50% of our tests are single limb in nature. Again, we go to our key positions. We set our reference point, the medial aspect of the foot. We note any deviations at retrotransumberg. And then the magnitude of the deviation is the one that we score the motion on. So in here, she's adducting past midline. And we see her do that again on another repetition and another repetition. And the final one is a single leg hop. Knowing that this is a steeplechase and a bounding and jumping athlete, obviously this is an important motion. Again, I think any of us that see that motion, we can see notable deviation. Again, we go to our key positions, we set our reference line, and then we measure adduction towards midline or past midline. We see in several of these motions that she's passing midline, and we're scoring that accordingly. So that's partly how we're using Dartfish, and again, even with an elite level athlete such as this, we're able to measure her movement in a very significant and profound way. Here's a summary of some of the movements that we just showed and what the scores were on each one of those movements and how we tend to report these for either our athlete, our coach, athletic trainer, or physician. Ella? Okay, so we are having some technical difficulties, so I'm going to go ahead and continue on.
I'm here.
Oh, okay.
I'm here. Can you hear me?
Okay, go ahead, Ella. Yep.
Okay, thank you, Trent. Hi, everybody. Thank you for that wonderful introduction. Let's look now at what we know about this as a starting point. We have, in this body of work, focused on non-contact injuries because we believe that this is an area in which we can have a profound impact and that really is directly correlated to the pathokinematics we see in the dynamic movement assessment. We know there are many contributing factors to pathokinematics and poor movement patterns as we define them, and they include hormonal factors, structural factors, femoral notch, size of the ACL, Q angle, and so forth. There are gender differences, obviously, that cause movement patterns to be different. There are biomechanical factors that contribute, neuromuscular factors, and many other beyond the scope of today's presentation. Some factors can be changed with training, however, and these are the ones that we focus on in this body of work. So our primary focus for today's webinar is to look at prevention and performance enhancement as it's related to pathokinematic movement patterns, which we see in the DMA, as Trent has just demonstrated, and can capture with Dartfish software. Our mission at Accelerated Conditioning and Learning is really to profoundly reduce injuries and dramatically improve performance or in athletics or activities that require athletic activity using the most technologically advanced research-based movement assessment techniques and interventions. So let's look at what's not in the literature today. These are questions that we could ask ourselves so that we can be sure that this is moving us in the right direction. We don't see in the literature the impact of pathokinematics directly on performance or how to quantify pathological movement. And that is, these two facts are part of what has inspired us to develop the DMA. We do not see in the literature a direct correlation between the impact of fatigue on movement patterns and the breakdown of movement patterns. However, we know that this is true, and it does occur because injuries occur later in the game after the athlete or person in motion becomes fatigued. We do not see a lot on how to interpret movement or how improvement in pathokinematics can improve performance. Finally, we have attempted to examine the role technology can play in assessing movement so that we are able to capture and educate and ensure the efficacy and efficiency of our interventions over time. In order to do that, we know we have to be able to capture the individual in motion, show him or her how he is moving for education and buy-in purposes, and ultimately we have to be able to remeasure using the same tool at a later time to see if our interventions have worked. Now, let me go over a couple of disclaimers with you. This is not the end-all, be-all. There are many tools available that all play an important role in identifying pathokinematics and correcting them. Prevention, when we talk prevention, we know that we are in essence saying we have kept something from happening. Because it has not happened, it is difficult to prove that it would have happened. However, we can see from the literature and from the evidence that Trent has presented earlier that we know these are very real-life injuries that are happening every day. And we have in our preliminary research shown that we can reduce the incidence of these injuries. So our hypothesis for today is that pathokinematics are directly related to the risk of injury and that they can also, therefore, affect performance. And Trent will get into more of that in a moment. The DMA is, in effect, a battery of tests. These are not new tests. They have each come directly from the research over the past decade and more. We have combined them in a progressive series, meaning that each test is more difficult than the one before, so that we can more closely mimic the demands of sport, including the endurance component. We have also made our dynamic movement assessment focus, or at least 50% of the tests are single leg or single limb. A study from the American Journal of Sports Medicine came out March 3rd of this year showing that single leg testing has a higher correlation to sport and is also a better predictor of pathokinematics. And so we have designed our test to test the athlete in single leg situations. Now finally, before I turn it back to Trent, a word about the pictures and videos. The pictures and videos that you see in today's presentation are real-life pictures and videos. We have not in any way doctored them or posed the athletes so that for demonstration purposes. These are real athletes, many of them very high performing, that are really moving this way. So let's look at the definition of pathokinematics next. We define pathokinematics as movement patterns seen during functional activities that result in abnormal force production and attenuation along the kinetic chain. Trent?
Thank you, Ella. When talking about pathokinematics and specifically related to lower kinetic chain issues, one common debate that is often brought up is that a distal issue or is that a proximal issue? Is that something that's happening at the foot and the ankle, or is that something that's happening at the core and the hip? The beauty of using video technology is it has really allowed us to really focus in on what we feel is the root cause of the movement pattern that is presented. In our course, we actually go through different presentations with lower foot and ankle versus hip presentations. The beauty of video technology and being able to slow movement down frame by frame by frame allows us to get a much better idea or representation of where that movement is coming from. Our hypothesis is that the joint that falls first, the weak link, will fall first, and it will be followed by the other link. So if that's a foot and ankle issue, you'll see the foot and ankle fall first, followed by the hip, and vice versa. That, for us, has dramatically changed our interventions and drastically improved our outcomes. To to give you a perfect example of what pathological movement does to the entire kinetic chain, we take a look at this young football player, a D2 football player who had 4 months of post-op rehab, not with us, who was on an accelerated program and was being returned to sport. This particular shot was done as a part of the dynamic movement assessment and was done pre-fatigue. We also got an x-ray of his lower lumbar spine during this motion so that we could see how is he actually moving and what is the impact of that on his spine. And as we see, I think any of us can look at the picture of him and see that that's going to put more wear and tear, obviously on his right hip, his right foot and ankle, his right knee, but also what does that do for the lower lumbar spine? Typical presentation, if there is a typical presentation, everybody presents a little bit differently, and one of the things that has been, as we've filmed thousands and thousands of these athletes, one of the things that's been an eye-opening experience for me is there is no typical presentation. But if we had to put it in typical terms, one of the typical presentations would be shoulder depression, postural thoracic scoliosis, lumbar side bending, Trendelenburg at the hip, hip adduction, femoral internal rotation, genu valgum, and pes planus. Obviously the entire kinetic chain or lower kinetic chain. And it may be one component of that or it may be all the components of that. When looking at normal force production, in quotes, what is really normal? And do we actually see normal? I would debate whether we actually truly see normal movement. But what normal movement should happen, or what should happen with normal movement, in giving the example of a jump stop or a drop jump or a jump squat, there should be symmetrical weight bearing during landing. Landing should be a soft landing versus a hard landing. And anyone who's evaluated movement or jump stops in a basketball court can very easily tell those who are having those soft landings versus those who are having those hard landings. At the hips, there should be a fairly neutral positioning of the hips without excessive adduction or abduction. One of the things that we also try to really make sure that we're doing during the dynamic movement assessment is seeing at what phase are we seeing these movement patterns occur. Are we seeing these occur more during the loading or eccentric phases, or are we seeing these occur more during the concentric phases? And the reason that that's important for us is that one of the things that it's really done is drive our interventions. From the specificity standpoint, we know that if we're having an eccentric problem, that if we train eccentrically, we're going to have a much better outcome than if we can train concentrically. So identifying what part of the motion that is occurring is important. So let's take a look at another athlete. This particular athlete is a 15-year-old soccer player, and I think anyone who sees her in motion can easily identify where her problems are. Again, Ella said that none of these are doctored. This is an actual photo, actual video of an athlete, soccer player, who was performing plyometrics as a part of her rehabilitation protocol. Again, not with us, but after viewing this and her being released to return to sport, but still complaining of pain, I think any of us can see with her movement why she may be complaining of pain. With Dartfish, I'm going to my key positions. I can see how is she positioning her feet for landing. I can see what is her maximal adduction. I can see what is her ankle position during loading activity. And then I can also see, again, what is her maximal adduction. The ironic thing here is, even though we may think that she may be in for a hip problem or a knee problem, she was actually in for an ankle problem. So just one other example of how profound some of these movements that we see with our younger athletes, even at a higher level. So what are the problems with pathokinematics? Well, first and foremost is that it loads tissues in ways that they're not meant to be loaded. You know, if we take just very quick examples of the lumbar spine, we know that the bone-disc bone interface supposed to be loaded with 80% of the weight. The facet joints were 20% of the weight. If we go back to our young football player where we saw him in that side bending position, we know that the facet loading in that particular instance is going to be much, much higher. We're loading those tissues in a fashion that they're not meant to be loaded. If we go back to our soccer player and looking at what those compression forces are, we know that articular cartilage is meant for compression. It's not designed for shear forces. Shear forces causes it to break down much, much faster. I think any of us can see with her shear forces that would be represented at her hip, at her knee, and at her foot and ankle. So some possible injuries that we see with these types of pathokinematics going from the foot and ankle on up. With pes planus, obviously we see a lot of plantar fasciitis, Achilles tendonitis, stress fractures. With the genu valgum, internal rotation, etc. We see meniscal injuries, ACL injuries. We see a tremendous amount of IT band friction syndrome and patellofemoral syndrome. Matter of fact, the next slide we're going to go over a case study of a patellar subluxation patient. Other things that we see with the hip adduction, piriformis syndrome, SI joint, trochanteric bursitis, and we're actually seeing a tremendous amount of labral tears in our young recruits in the military. Lumbar side bending, we're seeing SI joint pain, spondos, facet syndrome, etc. So these are just an example of some of the lower kinetic chain issues that you will see. Those who are truly massive lower kinetic chain issues will tend to present with one-sided kinetic chain issues. Repetitive injuries of the foot and the ankle, knee. They've also got hip problems or back problems on that side. Those cases are good examples of those that we would want to do a movement assessment on. So let's take a look at this young lady. I don't have a video of her, but this is her during a single leg squatting activity. 14-year-old volleyball player. She has had multiple patellar subluxations. Her last season, she went 2 seasons with patellar subluxations with physical therapy during the course of these 2 seasons. During her last season, she had to discontinue sport due to the level of pain that she was having and the amount of disability. After 2 failed bouts of physical therapy, she went back to her orthopedic surgeon and who had recommended a patellar relocation. Now take one moment to really look at that picture. Look at the position of her kneecap in relation to her foot. Her knee is pointing almost medial while her foot is pointing straight ahead. And I would speculate to say that if she were to have a patellar relocation, it may not correct what her problem was. The great thing about her is that we did a movement assessment on her. We gave her some interventions, and over the course of time, she was able to return back to sport. Matter of fact, her last 2 seasons, she won the most valuable player on her team, and this year she actually made the national travel volleyball team in her area. So what is the impact on performance? Besides case studies like that, are there a direct influence on performance? You know, we've had a tremendous amount of research related to pathokinematics in general in the relation to injury risk. We know that the larger the magnitude of the deviation that they have, the greater risk of injury that they're at. But what does that mean for performance? Well, we tried to assess that in an unpublished study that we did at Baptist Sports Medicine. We had an N value of 40, mean age of 16.5 years. We had 19 females, 21 males. And basically what we did is we did the dynamic movement assessment. From that, we derived their intervention. We also measured 40-yard dash, and we measured vertical jump. Into the results, after the 12 weeks of training, we ended up with an average of a 4-inch increase in vertical jump and a 1.4-second improvement in 40-yard dash time. Now, that sounds astronomical results, but thinking about it, these are young athletes, untrained athletes, and all of a sudden we did this training regime that was very individualized. So is that the result of the dynamic movement assessment, or is that the result of the training that was applied? I would think it was probably a combination of both, but really the fact that the program was individualized to that individual athlete and hence the reason that we had such a huge change in overall performance. So what are the factors that are contributing to pathokinematics? I could really spend the next 30 slides going over all of the research that's related to pathokinematics. But as you look at the research, one of the things that is abundantly clear is that there are themes that keep coming up. We know that the foot and the ankle fit into that. We know that hip strength is a major role. We know that proprioception is a major role. We know that core strength and endurance is a major role. We also know that there is overall athletic endurance that plays into this. We also know that there's gender differences, whether it's with Q angles, et cetera. But we also know that there's also physiological changes within females versus males. Red blood cell counts in females is lower, so oxygen transportation is less. So that adds into some of the endurance issues with our males versus our female athletes. The thing that I want to make clear as well is that there's been several papers that have been published as well as presented at the American Academy of Sports Medicine meetings that shows that there is also the same movement patterns that we see in athletics also carry over to recruits and tactical occupations. So these same pathological movement patterns that we see in athletics, we're also seeing in these higher demand sports or higher demand occupations. So what are some of the contributing factors? One of the things that another unpublished study that we did at Baptist, this one was done over 3 years. We had over 700 athletes that we looked at over 3 years. Basically what we were trying to do is to see how could we impact athletic injuries and really assess those that are at risk during high school physicals. Anyone who's been involved in high school physicals knows that no matter what you do in high school physicals, it's got to be efficient. So we wanted to test both the ease of implementation during high school physicals and at the same time also be able to assess which is the better predictor. So we looked at the functional limit screen, the star excursion balance test, and the 12-inch drop test. And what we found was basically that the star excursion balance test was the easiest to implement. For those of you that have not seen it, the young lady in this picture is demonstrating the star excursion balance test. One thing that became abundantly clear is that if you're screening a lot of volleyball players or basketball players, that the platform that she is standing on will be way too short for that. And that's one of the things that fits into some of the drawbacks of it. But that being said, it was one of the easiest to implement, and it was one of the highest predictors. But one of the things that I found really interesting was that we were finding that a lot of our female athletes were really failing on the star excursion balance test. And the 3 motions that we tested with the star excursion balance test was medial lateral, posterior lateral, posterior, and posterior medial. And what we found is that when athletes got into that posterior medial movement, that they were really losing it. They were losing their control and ability to control there. And that's really where we came up with the term lumbar hip dissociation. And what we mean when we say that term is an athlete's inability to discern the difference between lumbar flexion and hip flexion. And it's actually guided some of our interventions that we're doing with our current study and had some great results with, is really working on that ability for an athlete to discern that lumbar motion from that hip motion, and whether that's a flexion motion or a rotational motion, that once you teach them how to do that, that control becomes much, much greater. So what do we know? We know there's a lot of factors that contribute to pathokinematics, and we know that you can only assess it with movement. The current methodology that's out there is, we have a lot of different methodologies that are out there to assess it, and all of them have their strengths and their weaknesses. But how do we really capture, quantify, and measure the results of our intervention? I put up there one of the studies from March issue 2013 looking at single leg testing versus other bilateral testing. And one of the things that has become very apparent in the literature is that single leg testing has a much better carryover to sport and is a much better predictor or a way to actually capture some of the pathokinematics that are associated with sports activities. So some of the current tools on the market, there's a lot of great tools out there, and they all have a lot of great strengths. Some of the drawbacks from some of those are subjectivity, and really many of them are creating a very objective way to quantify these movements has been very difficult to do. Also, some of the drawback is the inability to assess what we call the true athletic profile. How does the athlete look in participation? It's one thing to see how they look in 3 isolated repetitions or whatnot, but how do they actually look when they're participating in athletics? That's what we want to capture, because that's what we want to improve. The other thing is lack of athletic intensity. You know, in athletics, ground reaction forces range anywhere from 3 times body weight to 8 times body weight. We have got to have some way of pushing an athlete during those types of testing protocols so that we can actually see how are they going to respond under those kind of loading types of activities. And finally is lack of single leg testing. You know, the research has been showing us for a while that single leg testing is important, and we need to consider that as a part of our overall assessment. So with the dynamic movement assessment, it will capture the mechanics that we know from the literature are directly correlated to increased risk for injury. It is athletically challenging. The dynamic movement assessment consists of 80 repetitions and 3 one-minute time tests. So it is tough. When you combine the fatigue dynamic movement assessment, which has a fatigue protocol with it, the average D1 athlete, the average pro athlete, rates this an 8 out of 10. It is that tough. It's sport specific. Because of the single limb testing and because of many of the motions are associated with sports, it is very sport specific, and it is single limb activity specific. It also allows us to quantify the magnitude of the deviation. We know from the research that the magnitude of the deviation is directly correlated to the increased risk for injury, and that's one of the things that this test will do. It also allows us to retest or reassess our interventions. At the end of the day, if we're not impacting the motion, it doesn't really matter what we're doing because we're not impacting the motion. And what this does is it allows us to go back and see, are we really impacting the movements that we're trying to assess? So how is it different? The 2 main things is that it captures the magnitude and the number of deviations. It also provides visual feedback. With the use of Dartfish, this is absolutely critical to the success of a dynamic movement assessment, because it's one thing for me to say, I see this or I see that. It's totally another for an athlete to see their motion. When you saw those videos, when you saw those motions, when you see those pictures, it is so much more powerful, 1. And 2, from a motor learning perspective, we know it takes 3,000 to 30,000 repetitions to change a motor plan in the primary motor cortex. Part of that that feeds into those repetitions is visual, seeing it visually, and mental rehearsal. And so knowing what the movement is, seeing what the movement is, that mental rehearsal piece of it plays a much better role. But the other piece of that with the visual feedback is it gets the athlete's buy-in. It gets the coach's buy-in. It gets the parents' buy-in. So when they see that motion, not only can they see how that's going to impact their risk for injury, but you can also see how that's going to impact my vertical jump, my 40-yard dash, etc. With the fatigue dynamic movement assessment, it simulates sport-like conditions. It is very, very tough. And it's always surprising to me when we take an athlete through this, and a high-level athlete through this, how fatigued and how worn out they actually get. So the purpose of the dynamic movement assessment is to accurately quantify human movement, pathological movement. It is to provide a valid interpretation of movement and, most importantly, to be easily integrated into whatever system it is. For me, as Joe Below PT, to tell anybody to go to a top-level team, university, a training center, or whatever, and say that you're going to do this, this, or this, is very difficult to do. But having the movement assessment, seeing what the movements are, there are some correctives that we feel very strongly about incorporating, but also, more importantly, is carrying those movement patterns over to whatever training regime that you use, whether it's with squats, lunges, snatch, whatever, is just getting an understanding of what the movements are and correcting those with all training methodology, whatever that training methodology is, so it has a higher carryover to sport. So what is it? It allows us to quantify movement, make hypotheses about mobility, strength endurance, proprioception, injury potential, and performance potential. And it also allows us to reassess the effectiveness of our corrective exercise program. So no matter what, if we think our interventions are the interventions, and we go back and we're not seeing an impact on the movement, that tells us that we need to kind of go back to the drawing board. The dynamic movement assessment consists of 6 essential movements. Each of those are filmed using Dartfish, and then we score those based on how they present during the movements. It allows us to quantify the movement, and most importantly, in that very first session, it allows us to start the educational process for the patient or the athlete so that they understand what the motion is and what their role is in correcting that motion. The dynamic movement assessment is also a progressive assessment, and that's very important because what it allows us to do is to progressively go through this exercise so that as it gets more and more difficult, we are challenging the athlete to a higher and higher degree. And secondly is that from that, we know that athletes who fail earlier in our test and those who fail later in our test, that those that fail earlier are at greater risk than those who fail later, because they're performing the easier exercises and already presenting with these pathological movements. The fatigue dynamic movement assessment, we tend to use this just for our elite athletes. And why is that? It's because it is that difficult. Our average D1 athlete, again, is rating this as a 8 out of 10, and we're using it in some cases with high school athletes that are going to being recruited by a D1 college, or some of our high-level college athletes that are being recruited to the pros. The dynamic movement assessment uses a fatigue protocol. It can be any fatigue protocol. There's a lot of great fatigue protocols out of there. The one that we use is one that was published in the Journal of Athletic Training in January of 2012. Not anything that we have designed, but we feel of all of the fatigue protocols out there, one, it's the most research-based, it is sport-specific, and it only takes 5 minutes to do it. It's the functional agility short-term fatigue protocol. We do that prior, and then we do the dynamic movement assessment. Total time for this test is 15 minutes. So that is 15 minutes of continuous exercise. Keeping in mind, our average athlete is rating this an 8 out of 10 on intensity. And we feel that this allows us to get the true athletic profile for our athlete and really see what do they look like, not at the beginning of the game, not even in the middle of the game, but we get a better picture of what they look like later in the game. Later in the game when most injuries are going to occur, later in the game when most performance issues are going to occur. So the dynamic movement assessment in sports, just took a quick picture of the squatting motion in sports. I think any of us can see that squats play a big role in athletics, as well as the single leg motion and single leg squats in single leg hopping and jumping. The one thing I wanted to point out on the slide as well is the impact of movement in sport. One of the things that we are seeing is that we are improving the performance on the dynamic movement assessment is that when we go and we film these same athletes doing a jump style, or we film these same athletes and they're doing sprinting or lateral movements on the field, we're seeing that their mechanics are improving. So, you know, that's one of the always the major questions is, does this assessment, does improvement on this assessment result in improvements in the movements? The most important part of it is the movements on the field, the movements on the court. And we are seeing just that. So real quickly, some of our current research. This is a continuing study that we started in 2011, and we'll be continuing it all the way through this year. We're performing this with the American Sports Medicine Institute and Andrews Sports Medicine here in Birmingham, Alabama. We have 4 universities that have been participating. Subjects are female. The average, the age range is 18 to 24 years. Our N value right now is 102, and we'll be continuing this on over the course of the next couple of years. Our intervention group, we have 42, and that is D1 and D2 soccer. The median ratings of perceived exertion on the fatigue dynamic movement assessment was 8 out of 10 for all of our athletes. So again, just reemphasizes some of the intensity of that test. The other thing is that one of the things that became very apparent to us is there's research out there that is, we're starting to see more and more research related to fatigue. We all know that fatigue plays a major role. We're starting to see more research come out on pre-fatigue and post-fatigue. One of the things that became very apparent to us is the difference between pre-fatigue and post-fatigue. For us, one of the things that we did is we categorized our athletes, those that were at high risk, because those are the ones that we really wanted to make sure that we focused our intervention on. Why? Because they're the ones that are most likely to have the ACL injury, drive up healthcare costs, and spend the most time on the DL. And one of the things that we found is when we did the pre-fatigue dynamic movement assessment, we categorized 2% of those at high risk. When we did the post-fatigue dynamic movement assessment, 36% of those were rated as high risk. So all of our interventions have been developed around post-fatigue data. And we feel that that's one reason that we have had such a big impact on our intervention because we have changed it on the post-fatigue data versus pre-fatigue data. So what are our results? With our intervention group, over a 2-year period of time, we've had a 100% reduction in non-contact ACL injuries. We've had a 58.2% reduction in all other non-contact musculoskeletal injuries. The team has had its 2 best seasonal performance. In talking with the athletic trainers and the coaches, most feel like that's not necessarily as much of a result of the individual improved performance, but more of a improved performance as a team because key players are being kept on the field longer in the season, and carrying them over into their playoff season. One of the major things that, looking at this data, because our N value is still small, because the total number of ACL injuries over that same period of time is small, statistically, that 100% is not that significant, and hence why we are continuing this research project. But one of the things that is significant is the total healthcare savings. For this particular university, over a 2-year period, one sport, we have had a $200,000 healthcare savings. If we can do that, again, one more year, what we will see is the university will actually get a decrease in their premiums for the first time in 10 years. That is significant. Ella?
Okay, thanks. Let's look at how we're using this. Obviously, you've heard and you can see how this has lots of clinical applications, including rehab. We have worked with rehab businesses where they have created niche practice, cash pay service for injury prevention or performance improvement. Specialty programs can be developed as in health systems. Examples, we are seeing it used in performance training and coaching. Dartfish and the DMA definitely have a huge wow factor. I'm sure you can get a sense of that here, but it's even more profound when you show an athlete how they move. It can be used, obviously people love to see themselves on video, you know that, working in your field. As Trent mentioned also, it has a very important learning and reprogramming effect to change movement patterns, and it can be used to educate the patient about what we mean when we describe pathological movement and possibly detrimental movement that will hurt them over time. So this tool is valuable in that way. And finally, it can be used to help get buy-in. Trent mentioned that from the athlete, his or her coaches, parents, the medical team, and so forth on what needs to be done and why. There's nothing better than video playback and video feedback for letting the athlete or the patient see him or herself in action. Of course, this tool can be used in complex cases, working with physician-owned PTs, PT practices, elites, pros, and so on. Now, we are also using this, as Trent mentioned, at college level and high school teams. Tactical operations can use this as well. Lots of opportunities for those of us in the professions represented here. Recently, there was an AOFSM conference presentation that showed that the same mechanics being seen in military recruits who have osteoarthritis rates the same as those in the civilian population associated with ACL reconstruction. So we know there's an application here. This is a great tool for integration into team physicals, and we're using it in that way, of course, and we've had a lot of success. We know it's driving performance and reducing injuries and saving money. We're seeing both an improvement across the board and an enthusiasm about this because it's new, it uses technology, it has wow factor, and we can show the efficacy of our interventions, as we've mentioned. So we can integrate this into current training methodologies, as mentioned, and education going forward. So we are continuing to research this. We need always and are committed to improving our research, expanding the depth and breadth of the research we're conducting. So we've mentioned that we're exploring the possibility of additional research with the Andrews Research and Education Institute. We have publications. We've mentioned the textbook, which will be online soon in e-version. Also, we published in March an article, a paper with the International Journal of Athletic Training and Therapy entitled Using Movement Assessment to Improve Performance and Reduce Injury Risk. And we have several others under review. Another way we use this is we offer courses and certifications. We host public continuing education workshops on the subject around the country. And our next one is going to be in Pensacola at the Andrews Institute in late June, June 28th and through 30th. It's 2.5 days, and the link is here if you're interested. Of course, we also offer custom and specially designed courses and education programs around this topic. Now, before I summarize and conclude, I want to say that at ACL and at Dartfish, we know that all of this information, the DMA, the software, and any great tools you have, are only as good as your ability to integrate them into your work. Use them efficiently with great results. Use them to differentiate yourself from other providers who do what you do. Satisfy your customers, and finally, you need to be able to make money doing it in most cases. So we work with clients to integrate these tools into the workflow to ensure that they, in fact, are useful, effective, and profitable for you. So in conclusion, let's say that we have attempted today to show in a very short period of time how the DMA and Dartfish can be used to bring down injury rates, drive performance, and help reduce the overall cost of health care. And we've seen how these tools can be integrated into the various settings. Dartfish has greatly increased the reliability of the DMA tool itself because we can see and objectively measure movement and remeasure over time, as we've discussed. And Dartfish TV has increased the reliability of the DMA corrective exercise program and other related interventions because we know we can more effectively control and standardize what is being instructed and how by using the video technology. Please feel free to write us for more information. This is our passion. We love to work with people who share the vision to reduce injury and improve performance. We hope you found this information informative and helpful. There will be more to come from us, and we so appreciate your involvement. We will now open the floor for questions. Thank you very much.
Thank you, Ella and Trent. This is amazing information. My role is to teach people how to utilize the Dartfish software, but it is so informative to see what you have, how you have applied it, and this has been great information. So we are recording this session, and we are going to send you that recording link. And if you have to leave the webinar, we understand we have hundreds on the line, and in your profession your time is very scheduled, but we will continue to record the questions because we have such good information, and you will get an email in a few hours that will have the recording link as well as the materials presented, a PDF of today's presentation and a bibliography with all of his research. So I'm just going to read some of these questions. We have some great information, and I will let you answer those. One of the questions Alan asked when you were talking about the pathokinematics and the lumbar testing, Trent, is why not a Y balance versus a star excursion?
You know, that's actually a great question, and I actually just recently, I sit on the editorial board for a peer-reviewed journal, and recently reviewed a submission related to the Y balance test. In a lot of their data, they were correlating that to the star excursion balance test. And one of the questions I had for the authors was with the Y balance test, one of the things that you have is you have one of your feet stationary and you have your opposite foot pushing a device. So essentially you have both feet, although you're supposed to be doing it lightly, in contact with the ground. Because of that, that data from the star excursion balance test cannot be carried over to the Y balance test, because the star excursion balance test, your foot is not to contact the ground, versus the Y balance where you actually have the closed kinetic chain activity with the moving limb, so to speak. So for me, it was more important to assess using the star excursion balance test, because in athletics, as we all know, our opposite limb in a single leg motion is typically not in a closed kinetic chain, and we felt like the star excursion balance test was a better representation of that.
Very good. And Milutin asks, when is your textbook going to be published? I know, Ella, you alluded to soon.
Yes. We are in the process. It's being programmed now for e-text distribution, and we expect that to be online and available in about 60 days.
Great.
Okay, and we have another question here from David. What are the 6 tests in the DMA?
The DMA consists of 6 motions. The squat, we call it the full squat test, step-up test, single leg squat test, single leg hop test, plank, and then the side plank bilateral, side plank right, side plank left. So collectively it's 6 tests, and 3 of those 6 tests are single limb in nature.
Okay,
Great.
and then another question related to the test itself, and this is from Carrie, is how do you define fatigue?
We define fatigue by using the fatigue protocol. And that's one of the reasons that we used the FAST FP, was that it was shown to take an athlete to 80% of their VO2 max. So what we do is we put them through the FAST FP, and then we take them through the dynamic movement assessment. So the assumption is that if you're following that protocol as published, that you should be taking them to what is 80% of their VO2 max. That is, occurs, it takes about 4 to 5 minutes, and then they are immediately performing the dynamic movement assessment, which consists of 80 repetitions and 3 one-minute time tests.
Okay, and then we have another related question. This is from Terrence. How do you quantify movement abnormality? What type of scoring system do you use?
We use a scoring system that utilizes Dartfish, and we score both the magnitude of the deviation and the number of deviations. In our course, we go through what the scoring methodology for that is, but it's basically scored on a 0 to a 3 level, with a 0 being pain or just the magnitude or the number of deviations is reached a certain point, and 3 being is that abnormal. So the overall score on the test is 21, but the score is based on both the number of deviations as well as the magnitude of the deviation. And we are actually automating that in a way that it makes it much easier for people to score, so that they don't have to go through, because at first it was very complex, and we've made that much easier and more automated.
Okay, and similar to that, how do you score specifically? How do you score a side plank, and is it timed?
The time, all of the tests are timed for purposes of standardizing the protocol. All of the tests remain at 1 minute. So if an athlete performs a plank test, for example, and they fail at 30 seconds, we have them continue for a 1 minute period of time. And the reason for that, or the thought process behind that, is that if you stop them at that 30 seconds, then their side plank, they walk into their side plank with more energy, more endurance, etc., to be able to perform the side plank. So from a standardization standpoint, all of those tests are performed for a 1 minute period of time. Using Dartfish, once again, what we do is we score them based on when they fall a certain amount of distance. So again, going through Dartfish, we film them, and we're able to see when they drop a certain amount, and then that's where their score is based off of, about how much time can they hold that position without falling out of this certain range.
Okay, and we have a question from Diallo, and I'm not sure if I'm pronouncing your name rightly, but can the DMA be performed without the use of Dartfish or any video?
It can be. The question then becomes, is it as reliable and valid as it is with video technology? I would say in a very skilled practitioner's hands, it may be. But one of the main reasons that we went to using Dartfish was the reason of trying to maintain the reliability and the validity of the movement that we are capturing. And initially, when I was doing this 15 years ago, I wasn't using it with video technology, and the one thing that always bothered me, clinically bothered me, was that I never felt like it was objective enough. And with the use of the video technology, it allows us to do that.
Okay, thank you. And we have a question from Tara. I'm curious to see some of your corrective strategies breakouts. Is something like that available, or how would you describe that?
Absolutely. In our course, we actually do almost a full day on corrective exercises. You know, one of the things that's very important to me is that, you know, exercises really, as we all know, is only limited by our imagination. I think any of us can come up with thousands and thousands of exercises to do. We do have specific exercises, specific corrective exercises that we do the first session we do that are able, that we have found have not only improved lateral shift. You can correct the lateral shift, even as significant as the one that we saw in the videos. You can correct that in 2 to 3 sessions. The lumbo-pelvic dissociation, you can correct that in 2 to 3 sessions. And so we have certain exercises and certain protocols that we feel pretty strongly about. At the same time, one whole half of our course is really going through therapeutic exercise, going through the dynamic movement assessment, and then also going through different interventions. And one of the things that I always find very valuable about doing courses is not only how much I instruct people, but also how much I learn from what other people bring to the table.
You know, that collaborative learning when you're all together in a group. So Timothy asks, what is involved in the certification, and where, again, is it available?
Yes, we have a course in June at the Anders Institute, and Ella mentioned the link, and I think we're going to be sending that link out to everybody. The certification course, the certification series is a series of 4 courses, and one of the big focuses for the certification course is really having people getting used to looking at movement. And so part of the requirement after going through the first course to the second course is a certain number of videoed assessments. And that way it allows people to start to get used to looking for the deviations that we talk about, getting used to the protocol for filming movement, educating on human movement, and then becoming an expert. That is our goal, is to take people along that process to becoming experts at looking at human movement and knowing this means this and this means this, and how you can create an intervention to change that.
Very good. And we probably have time for one more question. There is a question, so is the test scored live, or are you waiting till you're viewing video after all is completed?
The test is scored live, and we have a sheet that people will go through to generate their score. And what we encourage people to do is, especially if they're generating a report for someone, is just to go back through and just recheck themselves on the score, and specifically on the deviation, on the magnitude of the deviation. You know, you know, as you film more motion, as you film more of that, you can see when someone's adducting past midline. But are they having a 2-inch lateral shift versus a 3-inch lateral shift? That's really something that you need to kind of, you know, take literally 2 minutes to sit down on Dartfish and look at where you can actually score that. But most of the movements are scored live, and more importantly, the interventions, the education occurs live, and then the interventions are typically started that same session, at least in a clinical setting.
Can I add to that for a moment?
Sure.
I think too, although we do in those situations to do this live, we also have the ability with Dartfish to create media books and DVDs with the video recordings and the markups that Trent showed you in the presentation. And that can be given to the orthopedic surgeon, it can be given to the family, to the athlete, it can be put in the medical records. So it has the ability to be useful after the fact as well. and certainly can be pulled from the file for review after corrective interventions have been applied.
So it gives you a baseline to compare. That's great.
Yes.
Absolutely.
So thank you so much. We've gone 10 minutes over the hour, and these have been recorded, so we will send you all a link, but very informative. Thank you so much for your time. A lot of good comments and still questions coming in. I'll forward these to you, but thank you so much for today's presentation, and I know I, for one, have learned a lot of information, so thank you so much for your time.
Thank you, everybody.
Thank you.
We very much appreciate this, and thank you for sharing your passion.
Yes. And
Great.
thank you, Dartfish.
Great. Have a great day.
Thank you.